And preeclampsia is one of the leading causes of maternal morbidity and mortality around the world. It's also one of the leading causes of iatrogenic preterm delivery, leading to a lot of neonatal morbidity and mortality. So it is the most common medical complication of pregnancy, and therefore is something that we deal with every day. Because of the increasing maternal mortality rate around the world, actually, and in California, there were two major initiatives by American College of OBGYN, ACOG, and at the same time by the California Taskforce called the CMQCC, to try and see whether we can improve our management of this devastating disease. Well, actually, it's pretty simple. It's not rocket science. It's not brain surgery. There's 4 things you need to know about the classification: preeclampsia, chronic hypertension plus preeclampsia, and gestational hypertension. And there's 4 things about the management you need to know: control the blood pressure, prevent seizures, deliver them at the appropriate time, 34 weeks for severe preeclampsia, 37 weeks for all others. And then make sure that you don't forget that the postpartum period is really important. Thank you. I'm done with my talk. Thank you, Brendan. So ACOG, this was published just in November of 2013, the executive summary, which is a honking big thing to read, but if you have time, you should read it, particularly the part that addresses the anesthetic considerations. And then the CMQCC at the same time, instead of just looking at just discussing the disease, we've come up with what we call a toolkit, and Brendan mentioned the hemorrhage toolkit. We now have the preeclampsia toolkit, and we've got 2 more toolkits in the wings. This is just to show you that this is a multidisciplinary group which included obstetricians, nurses, anesthesiologists, and many, many other people. So preeclampsia is increasing dramatically in the United States, and preeclampsia is a leading cause of maternal perinatal morbidity and mortality, and there's about 50 to 60,000 maternal deaths worldwide. I live in Palo Alto, which has got about 60,000 people. So if you think about it, the total population of Palo Alto, one of Palo Alto dies every year from this disease. It's a devastating disease. And if we think about death as a sort of final endpoint, for every death, there's a lot of morbidity. The quote, near miss, where they try to die, but we don't let them. And I was just on service actually this last week, and this is a great typical week. I had a postpartum hemorrhage with a cesarean hysterectomy that almost did it for us. We then had a severe preeclampsia patient who demonstrated severe hypertension right after delivery during her C-section, and yesterday we had a MAC toxicity, all in 1 week. And I would not be standing here if it wasn't for my anesthetic colleagues who bailed me out on all 3 cases. So thank you very much. One of the problems is that less than optimal care has been noted to be really a big issue in taking care of these patients. And if we just followed our guidelines and gave optimal care, a lot of this injury may be avoidable. And as, I don't know if you can see the cartoon, as Pogo said, we have seen the enemy and it is us. What causes maternal death from preeclampsia? Well, if you look at the CDC review of US data, most of the patients died of CVAs or cerebrovascular accidents from hemorrhage, the patients from the preeclampsia-eclampsia group. That is something that we should really remember. And then in the state of California, as you can see that red arrow, maternal mortality rate is going the wrong way. And that has really prompted a lot of thinking about what can we do. And so the Maternal Mortality Review of the state of California, which is a multidisciplinary committee which I sit on and Sheila sat on, Sheila Cohen, and now Ed is on that. We look at all maternal deaths in the state of California, and we try and come up with ways that we can improve care by developing our toolkits. Because in the state of California, we have very similar data to the US, where 20% of the deaths were from preeclampsia, and in California, for a 2-year period, 17% of the deaths were from California. And here again is that sort of near-miss morbidity slide where you can see the red dot is the mortalities, but that's just the tip of the iceberg. We have a lot of morbidity that is associated with this disease, ICU stays, prolonged hospitalization, and sometimes long-term morbidity. We know that of all the maternal deaths, again in California, that over half of those patients had a diagnosis of hypertension somewhere in their medical history. So it is the most common complication of pregnancy. The other point that I mentioned was the less than optimal care. And from the California database, from the California data on mortality, if you look at the preeclampsia line that's outlined in red, you can see that when we review a case, we make a determination, was there a good chance, strong or good chance to alter outcome by employing standard methods of intervention, or no chance. So if you look at the amniotic fluid embolism one at the bottom, is there a pointer on this? No. If you look at the, not a very good pointer. If you look at the preeclampsia group, the important thing is there was a 50% chance, good to strong chance to alter outcome, and there was some chance to alter outcome in 50%. And there wasn't one case that we felt there was no chance to alter outcome. That's 0. If you look at the amniotic fluid embolism one, thanks, it's obviously very different. So we can make a difference, we being the healthcare providers. And we really do need everybody to follow best practice guidelines, particularly in the severe cases. But this disease continues to challenge us because there's confusion about classification and confusion about integrating the best practices into daily obstetrical practice. We also need to improve our patient education because the patients need to understand about the subtle symptoms of impending disaster with preeclampsia. So one of the most important things, and I mentioned to you there's the 4 things, is the classification. The classification led to endless debates in the ACOG HIP Taskforce. You know, you've heard the story about herding cats. Well, if you get on any of these big task forces, it's like herding cats. But at the end of the day, the ACOG task force decided that the 1972 classification, which is 50 years old now, was very good, and we stayed with the 72 classification. And those of you who are foodies in the audience, that's a 1972 Chateau Lafite de Rothschild, which supposedly was a very good year, and I think you can buy it today for $1,000. So the ACOG classification is just as good as this wine. It stood the test of time, and it's worth a lot of money today. So we end up staying with the original classification, and it's very simple. Preeclampsia, eclampsia is a syndrome, pregnancy-related syndrome after 20 weeks of gestation. That's number 1. Number 2 is chronic hypertension, and whatever the cause, it doesn't matter whether it's essential, renal, renovascular, loop, whatever. If they have chronic hypertension predating pregnancy, they fall into the chronic hypertension category. And simply number 3 is 1 plus 2. 1 plus 2 is 3, so number 3 is 1 plus 2. Chronic hypertension with superimposed preeclampsia, which is very common. About half of the patients with chronic hypertension, and in parentheses, vascular disease, will develop superimposed preeclampsia. And then number 4, sort of everything, once you've ruled out numbers 1, 2, and 3, you're left with number 4. That's the patient who just has hypertension, 140 over 90 or greater, and nothing else. I hate that classification because most patients move rapidly into one of the other classifications. But it is a classification, ACOG wants it, everybody else wants it, but please remember that these gestational hypertensives with no evidence of preeclampsia often are evolving. And this is the most important thing. This is an evolving disease. It's not static. This is a bit of an oh hell slide, but you look at it and say, oh hell, he doesn't want me to read that, does he? But this is the actual official diagnostic criteria for preeclampsia. And I just want to point out that, you know, the 140, 90, it's either 140 systolic or 90 diastolic or both, on 2 occasions 4 hours apart after 20 weeks, with a patient with a previous normal pressure. Very important that if you get to the levels of 160 over 110, that's called an acute hypertensive emergency. Just remember, 160 over 110 is an acute hypertensive emergency. Either 160 or 110, doesn't have to be both. It's an acute hypertensive emergency, and you do not wait for 4 hours. You confirm it within a few minutes, and then you treat them. Very important. Before, the previous guidelines did not include the statement, so a patient would come in with 180 over 120, they'd say, wait a minute, she doesn't have preeclampsia because it's not 4 hours apart, so they would wait until 4 hours later, and of course in that 4 hours the patient has a stroke and dies. So really important, simple stuff, but we need to focus on that. And then proteinuria is 300 milligrams in 24 hours. We all know that. We are now allowing the protein creatinine ratio of greater than 0.3 now, instead of having to do the 24-hour urine. But you may not have proteinuria in all cases. So if you don't have proteinuria, they can still have preeclampsia, and particularly if they have anything else, these criteria here, thrombocytopenia, renal insufficiency, etc., showing major end organ involvement. So you do not need proteinuria anymore. If you have hypertension plus one of these other criteria, you have got the disease. And if a patient walks in with new onset hypertension, she walks in with 140 or 90 or greater, or if she comes in with new onset proteinuria without hypertension, either one of those, 40% of them are going to go on and develop the classic form of the disease. So hypertension and or proteinuria is a marker for impending 40% of those patients get disease. So those are the patients that typically get sent home because they don't have both. In the old criteria, you needed both, and come back, severe hypertension, stroke, seizures, etc. So it's really important to recognize that those are important screening modalities. And again, patient education, and for us, when the patient complains of these things, we need to take it seriously. Now you're going to say, oh well, every pregnant patient complains of this at some point in time, and yes they do. They do. And this is the dilemma. But if the patient comes to you and says, I've just got this new onset headache, abdominal pain, I'm really short of breath, and I just swelled up like a balloon, my husband said I look terrible, you need to take it seriously. They should be brought in and evaluated. Doesn't mean you need to admit them and spend a lot of money. You just need to bring them in, check their blood pressure, and do some very simple laboratory studies. You just need to do a CBC with platelet count, look at their liver enzymes, look at their renal function with creatinine. If they have acute abdominal pain, you don't want to miss an acute fatty liver, so you add in the amylase, lipase, and ammonia. These are not expensive tests. They all get run automatically. So instead of just telling the patient to stay home when she says, I've got an acute headache or I'm swollen, she needs to come in, evaluate her blood pressure, get these studies, and you will then pick up or rule out the vast majority of these cases. The subset of preeclampsia, which is called severe preeclampsia, is based on blood pressure criteria of 160 or 110 or greater. Officially 4 hours apart, but of course if you hit these levels and you repeat them and they're the same, they need to be treated, or any of these other end organ manifestations. Really important that the 5 grams of proteinuria that was the basis of the previous severe preeclampsia criteria is now gone. Now, that doesn't mean that if somebody comes in with new onset 5 grams of protein, you say, oh, well, it's not a criteria anymore, send her home. It just means that it is not part of the criterion anymore for severe preeclampsia, because there's been no evidence that the level of proteinuria makes any difference to the outcome. If they've got proteinuria, it doesn't matter if they've got 300 milligrams or 5 grams, typically it doesn't make any difference to outcome. But it's really important because the severe preeclampsia group is the group that we worry about. And I just want to emphasize again that if somebody comes in with 160 or greater or 110 or greater, and it's persistent, which means you repeat it, and I wanted it to be 5 minutes, but the task force said 15 minutes, but you repeat it. And if it's persistent, you declare a hypertensive emergency in your mind and you treat them. You do not wait 4 hours. And then the antihypertensive medication should be given as soon as possible, but ACOG allowed a 30 to 60 minute window because they said in community hospitals they can't get the medication up as fast and so on. But we need to move and get these patients treated. And as I mentioned, the patient who had the severe hypertension during her C-section, her blood pressure just shot up and stayed up, and we ended up having to put on esmolol. And again, it can happen very quickly. This was a patient who had no hypertension, had a C-section. They're supposed to get better after delivery. Well, guess what? That's when her pressure spiked. So it's a treacherous disease. What we do not want to happen is to get to where what I call the deadly triad. The deadly triad is the severe preeclampsia group, the HELP syndrome, which is the subset of severe preeclampsia with hemolysis, elevated liver enzymes, and low platelets, or eclampsia with seizures, because once you get to the deadly triad, you have all these bad things happen, and none of these things that happen are good. They're all bad, including fetal and maternal death. So one of the things that ACOG has insisted on, which I'm very much in agreement with, is we don't talk about mild anymore. Mild preeclampsia always set this tone that, oh, it's not very bad. There's no such thing as a mild preeclamptic. Preeclampsia is a bad disease. So we are asking people to stop using the term mild and say preeclampsia with or without severe features. It's going to take a little bit of time. And as mentioned, proteinuria is not a requirement. The total amount doesn't matter, and we have to treat hypertension early. If you recall the slide, about 90% of patients in the US died of stroke, who died of preeclampsia died of stroke. We have very similar numbers in the California database, and it's hemorrhagic stroke, as you could see. Now, the UK figured this out a little earlier than we did, and you can see that our mortality from preeclampsia in California was twice that of the UK, and it all had to do with stroke. Basically, we had twice the number of strokes than the UK, and so we don't have to do a prospective randomized trial to prove that blood pressure control decreases the risk of stroke. That's like saying we have to do a randomized controlled trial that if you jump off the Golden Gate Bridge, you're going to die. We all know that's going to happen. So please remember that we don't have to do any more studies. You need to control blood pressure. Major contributors to prematurity, we're not going to talk about that today, and we're still left with a lot of unanswered questions. We do need to talk a little bit about gestational age. It is the patients who develop preeclampsia at 34 weeks or less usually, almost always, have the severe form of the disease. And if you look at this slide, you can see that 56% of our preeclampsia deaths occurred less than 36 weeks, whereas the non-preeclampsia deaths, about 37%. Severe preeclampsia is much more common in the early gestational ages, and if the patient comes in without evidence of severe features and she's less than 34 weeks, just wait. It's going to happen. So the British and the Canadians actually would like us to have a different designation for the less than 34-week group. They think it's a different disease, and it certainly acts very different to the 36-week, 140 over 90, 300 milligram protein patient who typically just has an indolent course and does okay. So it's really important to understand that the fact that severe preterm preeclampsia is the worst of this bad disease, and they can rapidly progress to severe maternal morbidity. And if a patient comes in with severe preeclampsia, preterm or term, they need to be seen by the obstetrical team, and this is because in many institutions they are seen by the emergency room, family medicine, then they get the internal medicine involved, and nobody calls the OB, and we have a problem. So if a patient is preterm between 24 and 34 weeks and comes in with severe preeclampsia, there is a very strict protocol of expectant management of these patients to try and buy some time. It's a very strict protocol. We bring them in, we give them corticosteroids for induction of lung maturity, we start them on seizure prophylaxis, we control their blood pressure, we make sure that they have adequate cardiopulmonary function, and then we can observe them. We get a 48-hour window to give them the steroids, keep them on MAG, keep assessing them, and then if they are stable, we can stop the magnesium for seizure prophylaxis, observe them. And most of the studies looking at expectant management between 24 and 34 weeks, you get between 5 and 10 days more time, which for a 24-weeker is a lot of time, good time. It's a good time for a baby if you can get 5 to 10 days, but you just have to be sure it's a good time for mom, because for mom sometimes it's a bad time. So it needs to be done in a tertiary center with people who do it all the time. It should not be done willy-nilly in a small institution where nobody's used to following these patients, because they need very careful assessment, and you need to know when it's time to bail. And if you get any of these severe end organ responses, headache, epigastric pain, renal failure, etc., it's time to bail and time to deliver, and because mom is going to get very, very sick. Now, I mentioned that we eliminated the term mild for preeclampsia, but they kept the term mild for the level of hypertension, which of course is totally inconsistent. And I just want to say that when you're on a committee like this, it's consensus. Doesn't mean we all agree with everything that we wrote, that was written. But I don't like this term, but it is there. So if you're less than 160 over 110 in terms of hypertension, so if you have gestational hypertension, which means you don't have preeclampsia, and it's not 160 over 110, you can wait on that patient. Or if you have preeclampsia without severe features, you can wait, but at 37 weeks you have to deliver. So 34 weeks for severe preeclampsia, 37 weeks for preeclampsia without severe features or gestational hypertension. This is causing a lot of trouble because at 37, we've got this initiative not to deliver anybody before 39 weeks electively, but this is an indicated delivery. And the study that's referenced here by Coopens et al. Showed that if you don't deliver by 37 weeks, either gestational hypertension or preeclampsia without severe features, they end up with severe hypertension and much higher maternal morbidity. So we know that in the developing world, the reasons that we have a lot of problems with preeclampsia is all of these lack of access, lack of care, lack of trained staff, lack of transportation. But if you look at all of these lack ofs, you can see that this is not only in the developing world, this occurs in our own country and in our own state of California. So there is a lot of work that needs to be done, but we can make a difference. And if you look at the factors contributing to the pregnancy-related deaths in California from preeclampsia, you can see a delay in diagnosis and use of ineffective treatment are the two leading causes. And that's on us, that's on the treating physicians, because we need to make the diagnosis, only 4 things, and we need to treat them. Treat the blood pressure, seizure prophylaxis. It is not rocket science. You may need to get some help get an organized tool to identify clinical signs. And this is another OHEL slide, but it's one of these nice checkoff lists that Julie Arafay and Nancy Peterson adapted from the British. From the British, it's basically a nice checkoff list for the nurses to go from green to yellow to red, and to do what you need to do. So, what can we do? It's a tragedy. Preeclampsia is a tragedy, and let's not worry about what Hamlet said, because what we can do is control their blood pressure, control their seizures, deliver them on time, and don't forget the postpartum period, because that famous Shakespearean sage, Yogi Berra, said, it ain't over till it's over. And it ain't over till it's over until 6 weeks postpartum. And the reason we brought that up is that if you look at the deaths, and this is weeks between the birth and maternal death, you can see that most of them occur day 0, but there's this tail that goes down into 3 and 4 weeks and even up to 5 weeks, because patients are not cured by delivery. Let's stop saying that. Cure is not delivery. Delivery is the most important therapeutic intervention to decrease the long-term and short-term and long-term effects of this devastating disease, this endothelial cell disorder, but it's not a cure. There's a tail. You still have endothelial cell damage, you still have end organ involvement that takes time to get better. And a lot of postpartum patients do come in with eclampsia. And with each eclamptic seizure, you have a 1% mortality. And if you look at the review of these cases of eclampsia, it can be very deceiving. 90% did not have proteinuria, and 20% didn't have hypertension when they came in postpartum with a seizure. And 30% did occur postpartum. And half of them occurred greater than 48 hours. So it's never over till it's over at 6 weeks. You got to remember that if a patient had preeclampsia, or even if she didn't, if she comes back with headache, visual disturbance, which is the most common presentation, and some hypertension, those patients often come to the emergency room, are never seen by an obstetrician or anybody who knows anything about pregnant women, and are sent home only to come back with major problems. So ACOG has suggested that if they've had preeclampsia, they need to be monitored for up to 72 hours, their blood pressure, postpartum, and then bring them back again within a week. But if they have symptoms, they come back earlier. So let's finish by summarizing the management. 4 things, we've spoken about that. Remember that the blood pressure control can be very controversial, because as late as 2012, ACOG was still talking about treating the diastolic hypertension, and it was only when Jim Martin and his group from Mississippi pointed out that most of the patients who stroked in Mississippi had systolic hypertension in the 160 or greater, and actually all of them were greater than 155, that suddenly the light went off and we said, we've got to control systolic hypertension. In the old ACOG criteria, they said anywhere between 160 and 180, you can start controlling systolic hypertension, but now we are focusing on systolic hypertension. And even though ACOG is saying 160 over 110, our CMQCC California Toolkit, we are giving you the option of treating at lower levels. That again is very individual, and you should certainly consult with your colleagues on that. We know at first-line therapy, it's either hydralazine or labetalol. You can also use oral nifedipine, and then you guys have got all the other antihypertensives in your armamentarium. Remember that magnesium sulfate is not an antihypertensive. It is not an antihypertensive. It's a seizure prevention. There's this myth out there that it causes, that is a good antihypertensive. It just causes a transient hypertensive effect, but it is not an antihypertensive. Specifically addressing the anesthetic considerations, the ACOG Taskforce said this, which I don't know if everybody agrees with, and Bob Geiser was on the ACOG Taskforce, that you should not stop the mag when you go to cesarean section. I don't know how many of you still do that. A lot of places we did it. Stop the mag. They're going to get atony and they're going to bleed. But the task force concluded, after looking at exhaustively through the literature, that you should continue throughout delivery because you could potentially end up with a subtherapeutic level and seizures. We totally leave the anesthetic considerations up to you guys, but we totally agree that neuraxial anesthesia is recommended if possible. And we do not use routine invasive monitoring. We know that MAG does work to reduce seizures, not a statistically significant reduction in maternal death, but clinically important. And it's clear that magnesium sulfate is a treatment of choice for severe preeclampsia and for eclampsia. The most controversial one is whether or not you should use it for patients who have preeclampsia without severe features. And ACOG has stated that it should not be used, but it does leave it open. If you read this convoluted language, it suggests that the magnesium sulfate not be administered universally, which allows you to use your clinical judgment if you want to use it for without severe features. And that's why in the CMQCC, we've left it up to the physician to decide, looking at the numbers needed to treat, whether to continue to use MAG or not. Very controversial, but we allow some clinical judgment. So it needs to be used for severe preeclampsia and for eclampsia. Just to finish off about the rapidity of being able to give the two most important drugs, the anti-seizure medication, MAG, and the antihypertensive medication, we have recommended development of a medication box, and this is the one from Stanford that Jill Hilton helped us put together. And you should all have something like this. It's very helpful. When we had a seizure, we showed that in the usual time that it takes to get everything going is 5 minutes or so. When we had a seizure, we pulled this box in and we had all the drugs in within 2 minutes. So it is probably a good idea to get that a preeclampsia box. I just want to mention again the postpartum issue, and we have to educate our patients. The patients should be educated according to their educational level. This is an example of a pictorial from the Preeclampsia Foundation, which is a lay group of survivors of preeclampsia, eclampsia, HELP syndrome. A very powerful lay group. We've got a lot of power in Congress, ACOG, and they are recommending that we educate our patients better, including use of something like this for lower socioeconomic patients. So, in summary, it's a bad disease, causes a lot of problems. We have come up with an approach that says it's a simple algorithm. There's 4 things for classification, there's 4 things for treatment. The CMQCC Toolkit has got a lot of little things that you can look at that will help you implement this in your institution. And I thank you for your attention, and I'll be happy to take questions at the break. Thank you.